Tokyolive Endoscopy 1.
1.
Hello, everyone. Welcome to this session. We are talking about the gastric poem. So today we have a great speakers. Yes, first from the Dr. Moen Kashav from Johns Hopkins. And the today's commentator is Kaise Mitsuru Sensei from Nihon Medical University. So they're world famous, great faculties. So I hope we make a good discussion. So first, I would like to introduce the professor of the Johns Hopkins University, Dr. Moen Kashav. So he is world first performer and reporter of the gastric poem. So, Dr. Kashav, please start your lecture.
Thank you, Professor Inoue. It's a pleasure to be here, and it's an honor to be invited by you to speak about gastric peroral endoscopic myotomy. I am going to share my screen here and just confirm that you see my slides, please. So my title is Gastric Poem, Indications and Technique. And these are my disclosures. Gastroparesis is a chronic disorder. The hospitalizations related to gastroparesis are increasing, especially here in the United States. We have very limited medications for gastroparesis. Metoclopramide has significant side effects and a black box warning. Gastric electric stimulation is not that effective. And also, it is a surgical procedure. What is wrong with gastric dysmotility? Some patients will have impaired gastric accommodation. Others will have antral hypomotility. Others will have increased pyloric resistance or pylorospasm, and many patients will have all of the above. As endoscopists, our role is in treating pylorospasm. How do we know that we have a role in treating pylorospasm? We know that Botox injection to the pylorus can be effective. We see this in our daily practice, although 2 randomized trials that I'm showing here did not show a positive effect of Botox injection into the pylorus, but both studies, I think, were underpowered. And if you count the total number of patients in both arms, in both studies, it was a total of 55. We move to transpyloric stenting. We know that from our prior publication and clinical experience is that placing a stent in some patients with gastroparesis helps improve the symptoms. We typically use this strategy. Sorry for that, it's advancing quickly here. We use this strategy to help discharge patients who are admitted with severe gastroparesis symptoms. Based on Botox injection results and transpyloric stenting results, we thought that gastric peroral endoscopic myotomy may be an option in patients with refractory gastroparesis. We thought about this back in 2013, where Dr. Inoue, myself, and Stavros from Winthrop in New York performed the first G-poem in a patient with severe refractory paresis with excellent results. G-poem disseminated since then, and it's now being performed throughout the world. How is G-poem performed? This is the step 1, which is formation of a bleb by submucosal injection of saline, methylene blue, and some epinephrine. Here, I use the triangular tip knife. My preference is for a longitudinal incision. And then using a gastroscope with a cap, same as we do with esophageal poem, we do a limited submucosal dissection to create some space, and then we enter into the submucosal space with our gastroscope and the clear cap that's on the tip. Then we move to step 2, which is tunneling. Same as we do in the esophagus, we tunnel towards the pylorus. Here, we also use the triangular tip knife and a spray coagulation current. We're always working on the surface of the muscle to protect the mucosa. Mucosal integrity is of paramount importance when we do third space endoscopy. We use the coag grasper to treat any large vessels in the way, and then we reach the pylorus that you can see here as a ring, and we see the duodenum running perpendicular and very close to the pylorus. This is clearly the pylorus ring. Then we move to the essential part of the procedure, which is the pyloromyotomy itself. My preference is to use an insulated tip knife for many reasons. One is you see that the duodenal mucosa is very close. So using this insulated tip, we protect the duodenum. Also, delineation of the muscle layers is difficult here. It's not as clear as the esophagus. So I use the ceramic tip to grab muscle and cut. If you are unable to grab tissue easily, it means you're deep enough, close to the serosal surface, and you should stop. Here, the cut has to be very slow and methodical. We want to avoid full thickness injury, and we should avoid entering into the peritoneum and risk injury to the bowels. So here, a full thickness pyloromyotomy was performed. And at the end, the last step is closure of the mucosal incision. Initially, we used clips. We had some difficulty sometimes, because in patients with a lot of food residue in the stomach, the mucosa can be inflamed. Also, the gastric mucosa is thick, and sometimes closure with clips is not as easy as it is in the esophagus. So this was closure using the Apollo device. But to be honest, there was a little bit of a learning curve, and we got over it. And I don't think, a clip closure is very difficult after you do some cases. Here I want to report to you a new device, also by Apollo, called the X-Tack device. This is a through-the-scope suturing device using these tacks. So the tacks get into the muscle, the 3.5 millimeter long between the eyelet and the tip. And these tacks with the barbs, they kind of hook to the muscularis propria and help with through-the-scope suturing. So this is the end of G poem. And then we can use these tags. We place tags on either side of the mucosal incision. And here we use a Z pattern to close. My preference for linear incisions is to use the Z pattern or a zigzag pattern. And for oval or circular incisions, to use a figure of 8. Each one of these systems comes with 4 tacks. After we place 4 tacks, we use this cinch, the same cinch that we use with the overstitch device. And occasionally we have to use a second system. As you can see here, there was a little mucosal opening at the proximal end of the incision. So my decision here was to place a second system to ensure complete closure, which was successful. So this is another method of suture closure using a through the scope suturing as opposed to the overstitch, which is an over the scope suturing. The system can go through any scope that you use. We move on. This is the first multi-center study on GPOEM. We published 4 years ago on 30 patients with different etiologies of gastroparesis. And you can see that 86% clinical response. Most patients had either a normalized gastric emptying scan afterwards or improved gastric emptying scan. There were no major adverse events, even with our initial experience. Procedure time used to be 72 minutes. Of course, now, after our extensive experience, it has gotten much faster. This is the report from the Cleveland Clinic on their first 100 patients who had GPOEM for refractory gastroparesis. We see that the gastroparesis cardinal symptom index score went down from 3.8 to 2.4, so that was a significant improvement. We see significant improvement in gastric emptying, and 63% of patients had normalized gastric emptying at 3 months. Very importantly here, I want you to pay attention to the index score, 3.8 to 2.4. This is very different from achalasia, where after POEM, most patients have minimal symptoms or no symptoms. Here, patients will have symptoms afterwards, but they have improvement in symptoms. Gastroparesis is not purely pylorospasm. So our thinking process should be different. Our expectations are different. GPOEM for diabetics versus non-diabetics. This is a study published a couple of years ago. We can see that there was no difference in response between diabetics and non-diabetics over 18 months with follow-up after GPOEM. This is a meta-analysis we put together. We see 82% clinical response, 2-point improvement in the cardinal symptom index score, that's significant, 23% improvement in gastric emptying. The most recent study we published is this international prospective study that was just published in Gut, again, multi-center prospective study. Here the results are not as impressive as you've seen in other retrospective studies. You can see clinical success at 12 months was about 56%, but our definition was strict. If you look at definitions in other studies, just go the score going below 2, the success goes about 66 to 68%. So anyways, we tell patients we see success generally in about 2/3 of patients. And by success, it means improvement in symptoms rather than resolution of symptoms. So again, our mindset should be different from achalasia. Some more results from this international study. This is the solid line is for patients who had success at 1 month. Dotted line is for those who did not have success at 1 month. You can see that success at 1 month predicted long-term success. So you can tell if GPOEM is going to work or not by the short-term success. In the vast majority of patients who had short-term success, they continued to have clinical success at 1 year. Importantly, we did a multivariable logistic regression model to understand which patients respond the best to GPOEM. And it turns that patients with a higher cardinal symptom score to start with, more than 2.6, respond very well. Patients with gastric retention more than 20% at 4 hours respond very well. Definition of gastroparesis is retention more than 10% at 4 hours. But if you basically select patients with severe symptoms and severe retention, this is going to be your best population to try GPOM. How can we improve the results? Here there are a couple of alternative techniques. I'm just going to report on one of them. This is a tunnel across the greater curvature and a tunnel across the lesser curvature. You know, some groups perform actual GPOM using a lesser curvature approach. I believe a greater curvature approach is easier. The myotomy itself is easier. But what if we try a bilateral approach or a double pyloromyotomy in patients with severe symptoms who are refractory to everything? Maybe that's going to help. Also, another alternative approach is to do 2 myotomies along the greater curvature, and then we snare the muscle in between. This is here just to show you how we perform myotomy along the lesser curvature. And then, of course, at the end, we can close both the mucosal incisions. And here, I believe we just close them with clips. EndoFlip currently is being used for patients with achalasia. It's a balloon that you place across sphincters, and it allows the measurement of the distensibility index. It's the narrowest area over the intraballoon pressure, and it gives us the distensibility of the sphincter. We have used it in patients with gastroparesis to understand how we can diagnose pylorospasm. This is how we perform it. We place a balloon across the pylorus sphincter and obtain the distensibility at different balloon volumes, 40, 50, and 60 cc's for the pylorus, 30, 40, and 50 cc's for the lower esophageal sphincter. And we've learned a lot from this. We can't make definitive recommendations, but I think we should continue to collect data on EndoFlip and learn how it can help us select patients. This is a recent editorial I wrote for CGH. This is how I select my patients. I use EndoFlip. EndoFlip, if the distensibility is more than 8 to 10, we exclude these patients. If the pylorus has low distensibility, basically less than 8, then we consider these patients for GPOM. If the distensibility is low, then we look at the clinical criteria. The clinical criteria: no major abdominal pain component, no major psychiatric comorbidities, no uncontrolled diabetes, no narcotics, and maybe some prior clinical response to pylorus-directed therapies. These are the patients we select for GPOM. Anteroduodenal manometry is important because if we open up the pylorus, but there is no anteroduodenal or there is enteral hypomotility, these patients should not respond. However, this is still a research question. We don't have a reliable way in clinical practice on how to diagnose this, but there's some increasing data on anteroduodenal manometry, including an improvement in the manometry catheter, and also some recent data on EndoFlip to look at the anteroduodenal manometry. So that's, I think, upcoming in the next couple of years. So to conclude, GPOM is feasible and it's very safe. Indications will continue to need to be determined. We know much better now than we used to know a few years ago. I think impedance planimetry or EndoFlip will help select patients. Double pyloromyotomy deserves further studyings, and RCTs comparing GPOM to sham and other interventional therapies are also needed. I'm excited to report that we are preparing for a GPOM versus sham study. And thank you for your attention. It's a pleasure to be here.
Yeah, thank you very much, Mo and Kashaf. So your great talk. So you cover the pioneering work in the very beginning of this procedure, and then also you mentioned the current new closing technique of the defect, and finally you talk about the diagnostic process algorithm to select the indication for this procedure. So thank you very much. So before moving on to the Kaisa Sensei's talk, we'd like to discuss a little bit about your great talk. So I have several questions. So so first I'd like to ask diagnostic process. So I totally understand scientifically. So limited the distensibility evaluation using end flip, and also you mentioned that the some dilation procedures effect of the dilation procedures is also informative. And then, so of course, we have to exclude uncontrolled diabetic mellitus or some other patient. We have to exclude it. So then, so you proceed the procedure. My question is clinical and practical, not the scientific, but the practical question. So myself, I do like this. The patient who has a gastroparesis or patient who complain of distension of the stomach at the time. So we do a balloon dilation of a pylorus. And then if a patient said that after pylorus dilation, the patient feels 2 or 3 days comfortable, eating well, and he or she, yes, digestion is very well. So if the patient said like that, we can proceed to GPOM. It's such kind of a simple criteria is stupid or dangerous.
No. So, the problem with this field is there is a high response to sham. So that's the thing, unless we have a blinded study, you'll never know, what's the truth. But I think a simple balloon dilation is better than just doing GPOM on all patients. It's a simple approach, but it's not very scientific, as you mentioned, And we've done, initially when I started doing this, as you know, what I used to do is I used to place a transpyloric stent or inject Botox. And if I see both improvement in symptoms over several weeks, in addition to improvement in gastric emptying, then these patients, we would select them for GPOM. But then this was a very complex process. And also it's expensive. More procedures, Botox is expensive, stents are very expensive, and stents migrate. And then we have to stitch them, more expensive, So it just is, and there is a high sham response or a placebo response. Then I just started depending on the algorithm that I mentioned, on clinical criteria, in addition to EndoFlip, in addition to after our recent data, we do want the gastric retention to be more than 20%. And I really believe this is important. For our sham-controlled RCT that's coming up, that we will start hopefully soon, one of the inclusion criteria is gastric retention more than 20% at 4 hours based on our prospective study.
Yeah, that's right. So gastric retention is, yes, first step, it's the most important. And so yes, that was a stupid question, sorry. You also mentioned about the severe disease. You do the bilateral myotomy of the pylorus. You mentioned. So is it a single session or your step? So first, one cut, and then if the response is not so perfect, then you proceed to second cut. So
yeah.
Would you comment?
So the bilateral approach, like lesser curvature and greater curvature, I have done it very selectively in patients who responded and then came back with symptoms. This patient that you saw, and I think I've discussed it with you, this video that you saw, the patient had a greater curvature pyloromyotomy before, and you saw how the muscle came back together, and I went back to the old video and the myotomy was adequate. So it wasn't an incomplete myotomy because, the area I think is very small and narrow, and the muscle can scar together, and so in these patients who come back, I do aggressive myotomy, either a bilateral or another technique we've been doing is along the same tunnel, the same greater curvature. You do two myotomies, one at like 5 o'clock and one at 7 o'clock. And then you snare the muscle in between. And that what that does, the myotomy edges, instead of being this close together, they are this far apart. So maybe it's hard for the muscle to come back together. We really don't know. But I have observed the muscle coming back together, and I showed you that video.
Okay, thank you so much. So, Kaiser Sensei, do you have any specific question at this moment?
Okay.
To Dr. Moen-Kashyap?
Yes, Professor Sherman, it's very nice presentation and informative. And I have a question about the mechanism of the refractory gastroparesis. I think that there is three main cause of the gastroparesis. One is, of course, you told about the pyloric spasm, and also reduced gastric peristalsis, and also the over gastric accommodation. So I think in the case of the pyloric spasm is main cause of the refractory gastroparesis. It is a good indication for the G plan, but you have to evaluate how about the gastric peristalsis or the accommodation. Do you have any data on the that are factors?
Yeah.
Do you comment about that?
Yeah. So thank you, and I think I've touched on this very important principle in my talk, and I hope I was clear. It's the gastroparesis is an extremely complex disorder with different pathophysiologies in different patients, and how much of each pathophysiology is contributing in each patient is also different. So maybe a patient has no pylorospasm, but we don't know. Maybe a patient has only pylorospasm, but we also don't know. There is now significant effort in trying to delineate what is the major pathophysiologic factor for patients. We're not there clinically. But in our planned study, I was discussing with Dr. Inoue, we will be doing endoflip, we will be doing anteroduodenal manometry, we will be doing EMG, we will be doing MRI scintigraphy and X-ray scintigraphy. And so we will be studying all of these factors and then doing GPOM afterwards so that we understand how these factors will predict outcomes. So our goal of this study goal is really patient selection to help with patient selection.
Yes.
There's absolutely right now nothing available clinically to help us answer your question. But the good thing is we're aware of that this is a problem and we need to resolve. And that's why when we do G-POEM, we see some improvement in symptoms. We don't see a resolution of symptoms because we're addressing one problem, not all the problem.
Okay. And also, you say that EndoFrep is good for the variation, the indication. And have you ever done the EndoFrep before G-POEM and after G-POEM? Because, you said that one of the possible mechanisms of failure is the myotomy, the muscle myotome with the myotome was just adheres and coming back again. So have you done the after G-POEM, the EndoFrep?
Yeah, so we have done that, and we published our data in gastrointestinal endoscopy, and we've shown that the increase in diameter afterwards is predictive of response. The data is not as extensive as it is in the esophagus. The esophagus, we look at endoflip and we can tell you a lot what these values mean. In the stomach, it's more difficult because to get the catheter there, it can be an issue. And also there is a lot of motility. In achalasia, the esophagus is mostly paralyzed. It doesn't move. In the stomach, you have tertiary contractions, you have retrograde contractions, so it's not as stable. So a little harder to get these results. Right. But we have some data that the increase in diameter correlates with clinical response.
Okay, so it may not you had the idea the double myotomy to get more diameter after the G-POEM, right?
Yeah, I think a study can be designed that way. Do one myotomy, do endoflip, and then do a second myotomy and do endoflip.
You're right.
So that's a great idea. We have not been doing it that way, but I think it's a great idea.
Yes.
So I think a double myotomy is similar to a myectomy. Is that right?
Yes, like in Zenker's myomectomy. Yes.
Yeah. So yes, thank you very much. Great talk. And Kaisa Sensei, you prepared one case.
Yes.
So if you like, would you proceed to your lecture?
Thank you very much. And I would like to share this, right? Can you see?
Yes, very well.
All right. Yes, I would like to introduce the first case of a G-POEM in Japan, successfully done Professor Inoue. This case is a 48-year-old man. He was suffered from the postprandial satiety and vomiting. His body weight reduced 10 kilograms for half of a year. And the EGD showed that a large amount of food residue are in the body. And pylorus looks like normal, but a little bit are spastic, and the endoscope can pass through the pylorus. And surprisingly, after pulling back the endoscope from the duodenum into the pylorus, donuts right here, protrusion of the prepyloric pylorus was observed. This finding are we observed about 1 or 2 minutes. So I think this sign looks like a very important of this patient to what is going on. And we tried to do the high resolution manometry using the Gastric forceps and a thread ligated on this probe. Because of the pyloric spasm, it's very hard to go through the probe into the duodenum. And then no relaxation of the pyloric vein was observed for 5 minutes. And this patient was diagnosed with gastric achalasia. Gastric achalasia means that are no relaxation of the pelvic ring during the all the time. So it's very similar to the esophageal achalasia. And we try to do the balloon dilatation, and the 15 millimeter in diameter is done. However, the 3 months after gastric dilatation, a large amount of food residue was still found. And then we referred this patient to Professor Inoue for G-plan. And Professor Inoue maybe our comment
Yes,
give
I can
us their comment that G-plan was successfully done, and his complaint of the postprandial satiety and vomiting disappeared. I hear that his body weight increased to the level same as before. So Professor Inoue, please make a comment.
Yes. So before commenting, it's a great case. It's actually a good collaboration. Can you see my slide? So G point is like this. So, okay, same photo. I remember very well. So, yes, Moen Kashyap, so he reported so case series. And this is a case, so Kaisa Sensei now talked. So this is actual procedure. Piles ring was actually tight. It's very difficult to pass through the endoscope. Then we perform the piles myotomy like this way. And then right after procedure, behind center of the image, you can see a very thin muscle layer. This is a bulbar muscle layer, and behind we can see a fat tissue that is a little peritoneum, I think. Anyway, we keep some mucosa intact, and then so both sides through the attachment, we can see a cut end of the pylorus muscle. Anyway, so we close the mucosa entry using a loop and the clip technique. Then, okay. So this is a case, and the patient's symptom are dramatically improved, and then patient satisfied so much. So that's results of the procedure.
Yes, I think the gastric achalasia is very rare case there, but it's very good indication for our G-plan because very similar to the esophageal achalasia. The gastric spasm is a main cause of the failure of the gastric emptying.
So Moen, would you like to comment on this case?
Yeah, I mean, I've seen some cases like that where the pylorus is very thick and it's very hard to pass the scope. I didn't call them gastric achalasia. We call them just a severe pylorus spasm. I think it's a great indication, and I had similar experiences with some patients with post-surgical gastroparesis, where the pylorus is extremely tight, and also I believe this is another good indication for G-POEM, post-surgical gastroparesis like post-Nissen or post-esophagectomy, these both will be great indications.
And also the infant pyloric stenosis is similar to the gastric achalasia. How about the indication of the infant pyloric stenosis?
Yeah, so there are some few reports out there. I'm aware of a group from China who has published over 20 patients with good results. But the procedure, I think it's extremely hard to perform. This is usually the weeks are a few days older.
Yes.
So the space is very narrow, and I know Dr. Inoue has performed esophageal POEM on a 2-year-old. I remember one time you mentioned, and it was extremely hard. So imagine a kid is a 1-week-old. I think it's a good indication. but you got to have significant experience in this field to do that.
Right.
Yeah, I also agree with Moen. So I have one case of a pediatric patient, but in that case, it's a good indication. I saw it beforehand, but we cannot complete the procedure because some fibrosis, small space, and the fibrosis. It's very difficult to complete the procedure. Honestly, I gave up to complete the procedure. So pediatric patient should be a very skillful hand.
All right.
So time running very fast. But today, we really appreciate Dr. Moen Kashav, your great talk, and the Kaiser Sensei as well. It's a great discussion and your great case. So this session, everybody enjoyed. So once again, thank you two guys, and have a nice day.
Thank you.
Thank you very much. Thank you very much.
Bye-bye.
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 Thank you.
Thank you.